These are influenced by your general health as well. Number one, you could choose observation. That's called watchful waiting. And what you would do is get a PSA once every 4 to 6 months from your urologist and sort of reconsider things each time. If the PSA is moving slowly, perhaps you'll choose not to undergo treatment at all. If it starts moving quickly and you get nervous for some reason, then you can talk to the urologist at that time about what your treatment options are and perhaps see a radiation oncologist again as well. Patients who are older and have more health problems, therefore likely to die of other things, are more likely to choose observation. So the lower the Gleason score, the higher the age, the higher other problems are, observation becomes a more attractive option.
Prostate cancer is a very slow-growing cancer. That means that it's likely on the order of 5 to 10 years before your prostate cancer would learn how to spread throughout your body, and even another 5 years past that before your prostate cancer would cause you to pass. That means it could be on the order of anywhere from 5 to 15 years before this could potentially cause you to pass. For many men, depending on their age and on their overall medical health, that may seem like a long time or a short time. And for some men, they may say that the risk of the side effects is worse than the risk of having this come back 5, 10 years down the line. For those men, watchful waiting is a good choice, and it's a choice that we've used for a long time. It's especially good for older men, men who have quite a few other medical problems, and men who also, along with those things, have tumors that are fairly early stage and often low Gleason score tumors, Gleason score 6 and below. The higher Gleason score tumors predict for a faster growing tumor, and those numbers of 5, 10, 15 years may be a bit generous for them.
Number 2 is a radical prostatectomy. That's done by your surgeon. I'm not going to discuss radical prostatectomies. That's what they do. They're familiar with the surgery as well as the potential complications. But again, for at least patients in the low risk category, that's a good option with a similar cure rate to the other treatment options as well.
Surgery on the prostate is fairly tough for the surgeon because the prostate is wedged fairly tightly into the pelvis. Because it is a fairly big surgery, most surgeons will have a cutoff in terms of age as well as in terms of comorbidities or other medical problems. Exactly where that cutoff comes will vary from surgeon to surgeon, and you should speak with your doctor if you're interested in surgery as an option. The main drawback of the surgery is that it really only takes care of tumor that's contained within the prostate, and if tumor has spread outside of the prostate, there is a chance of some of that being left behind in the pelvis. If that's left behind, that can potentially start to grow again and could mean you potentially would need radiation, either immediately after the surgery or even a few years down the line.
Number 3 are the radiation options. The radiation options take several forms. Our external form is now called intensity modulated radiation therapy. We have an internal form with seeds, or for patients with more advanced disease, we can do a combination.
Usually we use the seeds just for men with early stage favorable cancers. Those would be men who have tumors so small that you can't feel them on rectal exam, or if you can feel them, it's quite a small lump. Along with that, those men should have usually PSA scores less than 10 and usually Gleason scores of 6 or lower.